Hello, good afternoon. My name is Gerhard Prager. I'm the current president of IFSO European chapter, and it's my honor and privilege to welcome you to this webinar organized by Bariatric Solutions. Our topic today will be the bandit procedures, and the exact title is Bandit Gastric Bypass, Doing It Right the First Time. And we will have 4 main lectures given by Professor Jan-Willem Greve and Dr. Evert-Jan Boerma. We have more than 250 attendees registered, and please, if you have any questions, put them to the chat. Our first lecture will be 5-year results of primary bandit Roux-en-Y gastric bypass, presented by Dr. Boerma. He is currently working at the Dutch Obesity Clinic. He is a very experienced bariatric surgeon. He came initially from Rotterdam, had also some stays in the UK and at the NIH, and I'm really looking forward to have his lecture on 5 years results of primary bandit Roux-en-Y gastric bypass. Welcome to this webinar.
Thank you, Dr. Prager, for this very kind introduction. Good afternoon to all the attendees. As said, my name is Evert-Jan Boerma. I'm a bariatric surgeon at the Zuidland Medical Center and Dutch Obesity Clinic in the southern part of the Netherlands. My first presentation, or our first presentation, will be on the subject of 5-year results of primary Roux-en-Y gastric bypass. Here are my disclosures. An introduction for the majority who will probably know that bariatric surgery is the most effective and sustained treatment for obesity in the current era, and it's a treatment for obesity and, of course, its associated comorbidities. Although during the last years, the sleeve gastrectomy has surpassed the gastric bypass to become the most common bariatric procedure, still many believe that the gastric bypass is considered to be the gold standard of bariatric surgery. In bariatric surgery in general, and of course also in gastric bypass, we still have some issues to resolve. I think one of the most important one is the issue of weight regain, or maybe insufficient weight loss. Some propose adding a band as a solution for this problem, and in our center we decided to add a non-adjustable band, which we are doing since a number of years as a standard procedure. Of course, some people might worry about band-related complications in these patients. So therefore, I will present to you our recent paper published in Obesity Surgery at the end of last year, which was the majority of work was done by our Egyptian fellow Abderrahman Khalal in cooperation with our co-workers at the Dutch Obesity Clinic and in the Zuidland Hospital here. So what we did, we looked back in a retrospective case series starting from the 1st of January 2011 up to the 31st of March 2013, and we took all patients that underwent a bandit Roux-en-Y gastric bypass. Some details on the procedure are written down here. We started off making a 5 to 7 centimeters long vertical pouch, which we calibrated on a 40 French gastric bougie. Then we made a Roux-en-Y construction with a 120 centimeters elementary and 60 centimeters biliary limb. Both anastomoses were created by linear stapling, and the defects were closed by hand-sewn barbed wire closing. And at the very end of the procedure, we added a non-adjustable ring. In the lower part of this slide, you can actually appreciate in what kind of made. It was actually a transparent silicone tube, but for obvious reasons in this presentation we turned it blue. And just so you see, we created a ring by making an overlap of about 1 centimeter. So actually, when the tube was 8 centimeters, we created a ring for 7 centimeters, and of course a 6.5 centimeters, where we started off using a 7.5 centimeter tube, and later on changed to a 7 centimeters, for which I will come back the reason why. On the results in this period, 142 patients underwent Roux-en-Y gastric bypass. They were divided in 3 groups. The first group were the primary procedures, which was the very big majority. The second group had a conversion to banded Roux-en-Y gastric bypass, mainly from VBG for complications, usually problems with eating, or actually too high weight loss. The third group were people who had a previous bariatric procedure, gastric band, VBG, sleeve, and actually had weight regain or insufficient weight loss. For the goal of this procedure or this presentation, I will focus on the first and the third group. And in this lower schedule, you can actually appreciate the percentage of total weight loss, where in the blue bars you can see that we obtained a total weight loss percentage of almost 34% after 1 year, which stuck up there for up to at least 5 years. So that's the data we have now. The second group, who actually had a secondary or a conversion operation, did a little less concerning total weight loss, and they actually went up to almost 30% on 2 years, but actually sloped down on the longer term. Showing here are their percentage excessive weight loss, and you can see in the purple or maybe dark red line that the excessive weight loss is on, I think, a quite impressive percentage of an average 80%, and which stays up there up to 5 years. And you'll see in the yellow dashed line that actually the secondary or the conversion patients, after primary, well, more or less good results after 1 or 2 years, it drops down after 5 years, and hopefully it stabilizes at that point, but we're not sure to that. And although the weight loss figures in the primary procedures seem to stabilize after this period. So in here is another graph, another outcome measure where we see these results, the difference in BMI, and here we made a division on the dark red and the orange line between super obese patients, so patients with BMI over 50, going all the way down to an average BMI of 33, and the normal morbidly obese going down a little bit lower. So in both groups, I think we can say that there are good results on the long term. Well, as weight loss is not the only point where we're looking at, we have also watched comorbidity resolution. And in this graph where we see comorbidity of diabetes, hypercholesteremia, hypertension, and sleep apnea, you can appreciate here that in when you consider remission or at least improvement, that the far majority of patients had either remission or improvement, up to over 80% of patients on these comorbidities. And I think these are also good percentages after a follow-up of 5 years. The other side of the coin, so to say, of course, there have been some band-related complications. Here you can see an overview of all the patients who had a band-related complications in this series. There was a total of 9 patients out of 146 patients. In 1 patient, due to a migrated ring, we actually made a replacement of the ring, and during that procedure, we also revised the pouch and the gastrojejunectomy. And in 8 patients, the ring had to be removed. In 3 cases, this was due to erosion. And it's good to know, I think, that in 2 out of 3 of these cases, these rings could be removed by endoscopy and did not need any surgical interventions. And in the last 5 patients, actually, they were removed due to persistent dysphagia and were actually on the request of the patients or after deliberation with the patient. So to conclude, I think banded Roux-en-Y gastric bypass has good short and also long-term results in terms of weight loss as a primary procedure and maybe acceptable results after conversion. I think the advantage is on long-term weight loss maintenance and comorbidity resolution, and I think Professor Greven will show shortly in comparison with standard bypass. And seeing from our results, we think it's a safe procedure with acceptable incidence of band-related complications. And just to mention, for people who are also using it, I think that band size and position are critical factors to avoid these complications. As I mentioned earlier, we went up from 6.5 to 7 centimeters because in the previous slide, you can actually appreciate that the problems with dysphagia were especially there with 6.5 centimeters. And nowadays we are using a different non-adjustable band and we actually use 7 centimeters in female patients and 7.5 centimeters in male patients. And that reduced the number of dysphagia quite considerable. So that's for now. I think if there are any questions, I'm happy to give the word back to Dr. Prager.
Thank you very much for that very interesting talk. To our auditors, please post your questions in the chat room. We want to go through your questions. We want to really grill our presenters. Maybe I start with one question. You mentioned that the majority of erosions could be handled by endoscopy. How do you fix the ring or band? With absorbable sutures, non-absorbable? Do you take the remnant stomach to fix it, or what is your technique?
Yeah. So thank you for the question. So what we usually do, or what we always do actually, is use non-absorbable Prolene stitches, and we fix the band to the pouch itself. We do not attach it to the remnant stomach. In this case, there was 1 or 2 stitches, and nowadays when using the minimizer ring, we use the rings on the minimizer ring to fixate it with Prolene. So what I always hear from my gastroenterological colleagues, we see that if the problem is there, they can actually cut the non-absorbable sutures quite easily and then pull out the ring. If the ring is not fully eroded into the stomach, what they actually do is put in a stent, and then after 1 or 2 weeks, the ring is fully eroded into the pouch. They can grab it quite easily. You only have to cut the stitch and then pull it out, which is a, well, rather easy procedure, as I understand from them.
That's a fantastic trick you mentioned with the stent, and I think this is very important. What was the mean initial BMI in your group? Because your weight loss data are really outstanding with approximately 75% weight loss in the long-term run.
Yeah, so just to see, so I think the average on the whole group were around 44, and I think so there's a number of super obese patients in there, and and you can see here the results of the normal is the average is there 40.8. So I think, but it's well above 40.
Okay, thank you very much. I think we go on. Of course, we would have several more questions, but it's now my honor to welcome Professor Jan-Willem Greven. I think he doesn't need any introduction. Nevertheless, I will say, of course, a few words. He's one of the best known surgeons, not only in Europe, but maybe in the world. He was former IFSO World, was one of the founders of Dutch Obesity Clinic, and I think, Jan-Willem, you're very well known to our audience, and I'm very happy that you will now give us your lecture. The stage is yours.
Well, thank you very much, Gerhard, and also thank you to Bariatric Solutions for setting this podium for our presentations. Well, you've had a very nice introduction with our study on the 5-year follow-up of bypass, and I'll try to put it in a little bit more general perspective. These are my disclosures. I am a minimizer user, so that's one of the disclosures, but overall this does not affect the content of my presentation. Well, one of the things that I want to stress, and that is very interesting, the discussion in the literature has been going on, is that many surgeons nowadays say that you are not allowed to talk about restriction. But I'll show you that restriction really is important in all the treatments that we do. I'll try to give an overview of the literature. I'll show a little bit on band-related complications, and in the end, some results of our Dutch obesity clinics in the Netherlands in general. And that, I think, is a very strong argument for us to keep doing the banded bypass. Well, everybody knows this paper of Francesco Rubino, in which he divided the gastric bypass in 5 different operations. And one of them is the pouch that you make. It should be a small vertical pouch, not as on the picture, and it does provide restriction, apart from all the other factors involved in weight loss. And one of the things we have to realize is that our operations reduce intake of calories and carbohydrates, reduce glucose load, and there is weight loss. And by any type of procedure, weight loss is important. Of course, there's also the change in gut hormones, which has been very important over the past years, and many publications have focused on that. And of course, there's change in inflammatory mediators, and that is really something from the past, but it's still around. And it has also to do with the adipokines. And of course, there's a lot of research going on with regard to bile acids, very interesting, probably an important role, but it's one of the many factors involved. And of course, the microbiota, the bacteria in the gut, which are really different in patients with morbid obesity compared to patients that are not morbidly obese. But what we should not forget is that our adipose tissue is the largest endocrine organ that we have in our body, and it produces a huge amount of adipokines and cytokines, which many of them are related to weight maintenance, insulin sensitivity, etc., etc. So weight loss is important. Here, a little bit more detail, but the thing is that when there is more fat in the adipocyte, the patient will have insulin resistance, will have increased inflammatory mediators, etc. Now, of course, we also have to realize that surgery does not treat the underlying cause. It is a tool, and we know that all very well. But when you say, okay, you do a bypass and you change your gut hormones, patients with a bypass can regain weight, and then their comorbidities will return, as will after a restrictive type of procedure, of course. And in fact, even our most efficient operations, the malabsorptive procedures, which have a higher risk, do need restriction. When you go back in time and look at the development of the biliopancreatic diversion, also there's attention to the size of the stomach, because when you have a population that eats a lot of carbohydrates, you need a smaller pouch than those eating more proteins, which is North versus South Italy. So also there, restriction does play a role. And this is another interesting study. When you look at the long-term results, patients with a similar weight loss after a BPD or an adjustable gastric band have a similar effect on type 2 diabetes and other metabolic problems. So you can imagine why Nicolas Copinaro, which you see here on the picture, is looking a little bit worried. Anyway, the BPD, of course, is a better operation in terms of cardiovascular risk and in terms of long-term weight loss. But when you have a similar weight loss, even with a restrictive procedure, the effect is comparable. And also, pouch size and outlet size do matter. There are several studies about that. This is one looking at weight regain, showing that a larger pouch, a larger outlet, or a combination is often related to weight regain. And this is another study looking at outlet size. Patients with a silastic ring looked at the outlet diameter, and you see that there is a clear relation. The smaller the diameter, the better the weight loss. So yes, restriction does play a role. And that is probably one of the reasons why our surgeons in the past started to place bands around pouches. And Melphobe is one of these guys, of course. He did a lot of VBGs, converted a lot of them to bypass, and then saw that patients regained weight and started to leave the band in or to do a banded bypass. And here you see the typical Phobie pouch, which also included a gastric tube in the excluded stomach to prevent stomach dilatation. And then, of course, there are a lot of modifications of the bypass, looking at long limb, short limb, long biliary limb, longer pouch, etc. But that's not the topic of this presentation. What we look at is the band and the role of the band in patients with a gastric bypass. And what we have to realize that even after standard gastric bypass, up to 30% of the patients will regain weight in time. So I give a short review, and I will be very brief because the time is restricted. But when you go back in time, Henry Buchholz was one of the first to really put together a review of all studies with banded bypass, and you really can see that the long-term results of the banded bypass are comparable to the biliopancreatic diversion. So in comparison with the standard Roux-en-Y gastric bypass, there's a better weight loss, and it is maintained over a longer period of time. This is in a bit more detail, and again you see that all these banded bypass studies show a better weight loss overall. This is a study from Luc Lemmens from Belgium. This is a study with the Phobie ring, the gap ring. It's a prospective study, and you can see that he had a very nice weight loss after 4 years, which is comparable to the weight loss that we saw in our study, over 75% excess weight loss. Here, a study looking at also the higher BMI patients. So that is the super obese, and again you see a significant difference in excess weight loss in the banded versus the non-banded patients. Red is banded, yellow is non-banded. They had, in this series of 134 patients, 3 band-related complications, of which 2 erosions, which is quite comparable to the study you just heard the results of. Another study looking at banded bypass versus non-banded, and again there is a significant better weight loss after the banded bypass. And also looking at quality of life, although you would expect that the band will give some more complications in terms of quality of life, you see that there's really no big difference. And the banded bypass patients again had a better weight loss compared to the non-banded. Do all the studies do well with banded bypass? No, of course not. It is very dependent on type of band, band size, position of the band, and this is one of these particular studies where they used a pericardical patch ring to create the banded bypass. And they looked at the results, and on the long-term results, they saw absolutely no difference at 3 years between the banded and non-banded bypass. However, you have to realize that this pericardial patch is a biomaterial and will be resorbed over time. So it's quite understandable that you won't see a difference. Several meta-analyses have been done. I'm not going to go into detail because I'm running out of time with that. And one of these meta-analyses showed that you have a higher food intolerance after the banded bypass, but it is also technique related, a little bit more complications, but also a better weight loss. And when you really look into the details, then this study was not very well done. They switched the results of the banded and the non-banded. Dr. Bessler is Dr. Bessler, so he will not be happy about it. But anyway, you still, although the study was not very well done, see that there is a advanced weight loss in the patients with the band. Another review, a bit better done, looking at complications, leaks, obstruction, vomiting, not a big difference between the banded and non-banded groups. And when you look at the outcome, excess weight loss, there's a significant weight loss improvement in the banded group. And you have to realize that this study using the pericardic band was included. So in that study, there was no difference, and probably the overall weight loss will be even better than is shown right here. Again, Luc Lemmens comparing a historical series with his banded bypass gap ring group, looking specifically at weight regain. And I'll go back one slide, because one of the interesting things that he found, he didn't do many redos, but he had a number of patients that had increased food intake and then were found to have a broken ring. So they had no more restriction, and all these patients requested a new ring. Now here, looking at the results, the banded versus the non-banded. The banded have a better in percent BMI loss, as is in this slide. But more importantly, when you look at weight regain at 5 years, then there is a significant better result in the banded bypass weight. There's less patients, there's a non-weight regain over time. Another study looking at long-term follow-up, again, banded Roux-en-Y gastric bypass, and you see that here also the results are very good with and that's why I show it, a 1.2% band erosion rate. And as Dr. Boerma already nicely showed, most of these problems can be solved by endoscopic removal of the ring. And this is the long-term results in terms of total percent weight loss. And again, you see that over the long period of time, you have a very good result. This is a study looking at redo surgery, where after weight regain, bands were placed on the pouches, and you can see that also that has a significant effect on the long-term outcome. And I'm just moving quickly over to the next one. This is also looking at revisional procedure of a non-adjustable band. This is from the Netherlands. But there they saw a big difference in the patient that were initially good responders that had weight regain and the band was placed. They had a very good outcome. The initial poor responders regaining weight didn't do very well. They had some weight loss again after placing a band. But what is also interesting in this study is that in their initial series, they had quite a large number of bands removed. And you can clearly see that this is band size related. So when the band is too small, the patient will have too much problems, too much dysphagia, and will lead to earlier removal of the band. It was mentioned already, the band-related complications, band erosion, 1 to 3%. Some of the patients have really excessive weight loss. There you remove the band, and in general, they end up with a very good weight loss. And sometimes there's excessive vomiting and there's food intolerance. And I have some slides on that, but I think that because of time, I'll skip over. The funny thing is that when you look at food intolerance, you have a bit more food intolerance. They have looked at gastric emptying, etc., etc. Well, the gastric emptying is, of course, affected. And what is very interesting to see that you have more food intolerance, but for the foods that are good for the patient, the salads, the vegetables, you see that that is the green barrow, that they have no problems there. So it may even promote a better eating pattern. The upper panel is the banded and the lower panel is the non-banded bypass. The weight loss overall was here similar. Band erosions can be managed endoscopically. Dr. Boerma mentioned already, stenting is one of the ways to solve a partially eroded band. Leave it in probably a bit more than the 2 weeks, but when you remove the stent, usually the eroded band will come out together with the stent, and otherwise you can just cut the band and pull it out endoscopically. This is, by the way, a study looking at Marlix meshes, which is even more prone to erosions from our friend Gaudat from Egypt. But again, most of these patients with an erosion could be treated endoscopically. So here I'm coming to the conclusion of my presentation, and I think this is showing a very strong point. You see in the video how we place our band. It should be at least 2 centimeters above the gastrojejunectomy. We go through the mesentery of the stomach, and that is one point of fixation. And on the opposite side, we'll fix the band with Prolene on the pouch. But what I'm wanting to show is that we are part of the Dutch obesity clinics, which is 8 clinics totally doing annually about 6,000 procedures, and the majority of that is room-wide gastric bypass. And in fact, we are the only clinic doing a banded bypass, and all the others, most of them have adopted to the elegance, the long biliary limb gastric bypass, because of the good results. But when I show you the results, and this is from all these clinics together, the dotted line is the average result in terms of percent excess weight loss. But the top line that you see here are the results from our clinic, and you see that we on average have a significantly higher weight loss than the standard bypass. So even doing a elegance bypass, the banded bypass has on the long term a better weight loss. Here you see a similar graph, a bit more compressed, but looking at the results at up to 5 years. And here in numbers, and again, you see we have a very nice weight loss, total body weight loss of up to 30% after 5 years. And interestingly, we also do, since a few years, all the patients from the Eindhoven location. And you see that also there, we obtain similar type of weight loss. So to conclude, and I know it was very quick and very brief, I am personally really convinced that weight loss is important and that restriction plays an important role there. And weight loss is very important for the long-term result of our operations on comorbidity. Banded bypass gives that sustained long-term weight loss. And when you look at the band-related complications, that is fortunately limited. Band size is crucial, pouch size is probably crucial, and maybe it's time to do a very good randomized study looking at all these parts of the operation: pouch size, length of the pouch, size of the band, etc., and find the most perfect operation for all patients. Thank you.
Thank you very much, Jan Willem, for that great overview of literature and your own very convincing results, I must say. We have several questions from our audience, and just one interesting is, do you see a reduction in post-operative hypoglycemia in patients with banded bypass compared to non-banded Roux-en-Y gastric bypass?
Well, that is really an excellent and very interesting question. Yes, we see relatively few patients with hypoglycemia, but they are there. And in general, when this happens, these are patients that have stopped their diet. They start eating glucose or sugars.
Yeah.
Or they have a loss of restriction. And I don't have the case in my next presentation, but I had one very interesting case of a patient that had a banded bypass, then developed hypoglycemia, but she had a hiatal hernia. I operated on her. In that procedure, because of dysphagia, I opened up her band a little bit. She first had a non-banded, then a banded, got rid of her hypoglycemia. After I did the hiatal hernia, I opened the band a little bit because she had dysphagia. And after that repair, she had her hyperglycemia back again. So I had to go back again, close the band 0.5 centimeter, and everything is fine. So the restriction, yes, it's important. And we do have patients with hypoglycemia that need more restriction, that come from a different location, because we do nearly standard banded bypass. And it's certainly an option to put in a band and of course, reduce the size of the box. That's part of the redo.
Great. For the sake of time, we will maybe take the other questions later on. And I want to go to the next presentation again to Dr. Burma, primary banded bypass versus primary non-banded bypass, and banding only when necessary.
Thank you, Dr. Prager. So the next presentation will be on the decision either going for a primary banded Roux-en-Y gastric bypass versus a non-banded Roux-en-Y gastric bypass and banding patients only when necessary. This is more or less a philosophical discussion because there is no good trial on this subject. But just to take you on to show you a little bit of data which is there. So short introduction, as we all know, positive effects of Roux-en-Y gastric bypass are there. Effects on weight loss and comorbidity resolution are significant, although we still face a problem with weight loss, insufficient weight loss or weight regain in a number of patients. And as depicted in the graph below, that can be very troublesome for a number of patients there. We have nowadays, I think, several options for patients with weight regain or insufficient weight loss. I think they're stated here. I think everybody starts off with optimizing behavior of the patient. As we all know, the operation is more or less of a tool to help to change your behavior. And I think changing or training your behavior with a dietitian or a physiotherapist or coaching should be an essential step in every form of helping these patients. But as we know, the results of this therapy could be somewhat disappointing. Nowadays we have medical options. I think there are more and more medical options on the market there. In the Netherlands, they don't have a very strong foothold yet. I think in the United States there's a larger market, so to say, for these things. But I think these medical options will definitely evolve also in our country. So here in the Netherlands, I think we tend to grab to surgery quite often if we think we can help these patients offer a new chance, so to say. So one option, I think, there's conversion surgery. We all know band to bypass conversions. When you already have a bypass, a conversion to a different technique is somewhat worrisome. I think a conversion to a BPD or a duodenal switch is an option, although technically challenging and with rather significant morbidity, perhaps. So I think the more usual way to go is go to revisional surgery, where you stick to a Roux-en-Y gastric bypass and pick up one of the aspects of this bypass. So I think one option, as Professor Geef already mentioned, is limb lengthening, where you could either lengthen the elementary or the biliary limb. I think data showing now that the biliary limb is probably the way to go. But here in Heerlen, we are a bit worried about this because there is a very strict balance in this case. Because if you don't go distal enough, then you will see not very much effect of your revision. And if you go only a little bit too distal and you don't leave a lot of enough total alimentary tract in there, then you can get quite severe malnutrition and protein malabsorption, which is, I think, a very big problem. And then to follow up with a daging, which I was always learned to be very careful with combining restriction and malabsorption in one procedure, is, I think, is a lesson to take there. So the way we go is usually add additional restriction. So you have endoscopic options where which Professor Geef showed you shortly. And I think another option is, of course, to add a band. And this is a little bit older presentation of our group, where we showed that adding a adjustable band to a gastric bypass, this is a review of the studies out there, actually adds additional weight loss to patients. And from this graph, the results of this procedure are a little bit mixed. This is a more recent study where actually a group added a non-adjustable band, and in these patients you can actually see the initial BMI of the patient, then the BMI of the patients at revision, and then you can see the dotted line is actually when adding a non-adjustable band, you see only very little result on the additional weight loss, and this is of course where something to worry about. Is this the patients which were selected, or doesn't the technique itself add a lot of effect there? And maybe it's in the middle, because we all know that revisional surgery is a little bit more disappointing than primary surgery, maybe, because we all know that the effect of a revisional procedure is less than a primary procedure. Here you can see a nice study where they had very long follow-up of comparing primary Roux-en-Y gastric bypass versus secondary Roux-en-Y gastric bypass, and they definitely show a big difference in especially the long-term weight loss. And of course, this has to do with different patient selections, and the group needing a secondary procedure are probably different from, or a certain selection from the whole group of primary procedures. But it's probably also due to the metabolic state these patients are already in. They already had a bariatric procedure, so their basic metabolism rate is already lower, and adding an additional operation on this will make it a lot harder for these patients to drop additional weight. That's something I think which is there. So, also in our study, I think that this is a graph I already showed. Yep.
If you like, I can just show that slide that I promised to send to you, but I had some other things at my mind. Oh. So when we shift for a second, I'll show you one of the reasons why it's so difficult to lose weight after a surgical procedure before.
Shall I? Yep.
Yeah, there I go. So, do you see the presentation? Do you see the slide?
Yep, now it's there.
Yeah. Okay, sorry, I should stop the text because that is out of a lecture. One second, I have to remove the sound. I do it like this. Here you see a study that we did many years ago in patients with a VBG. And what you see is sleeping metabolic rate. The sleeping metabolic rate can be measured in a metabolic chamber, but you can also calculate that rate. And before the surgery, there is a relation of 1:1. After 3 months, you see that a very significant lower measured metabolic rate, sleeping metabolic rate, compared to what you would expect. And the thing is, it stays like that. This is after 3 years. It's the same after 10 years. So there's really something changing in your metabolism, making it important and making it much more difficult to lose weight after you do a revisional type of procedure. So I'll give it back to you. There you go.
Thank you, Professor Geven, for adding this. So I think that's what you just added and said, was that the basic metabolism of these patients is even harder to change after a secondary operation. That's what we also showed in the study I previously showed you, that cases with a primary banded gastric bypass, here in the top red line, shows very impressive results, and patients with a secondary procedure with a conversion to a banded Roux-en-Y gastric bypass are just less. And I think that's due to, might partly be due to the metabolic rate these patients already have lowered. So here showing again the graph which Professor Geven showed you already. Of course, you can do a primary gastric bypass, and only in the patients who fail who reach insufficient weight loss or go with weight regain, add a band, but the success there is questionable. I mean, you probably select patients which are having a harder time. And on the other side, as we show you in this graph again, is that when we compare our numbers, which is in the dark blue line here, compared to the other centers of the Dutch Obesity Clinic, which are more or less on the dashed line, we see that our results especially are a little bit higher, but I think for me, the most important difference is that their weight loss on the longer term is more sustained compared with the other ones who are dropping. So on that account, I think it is a wise decision to go for a primary banded Roux-en-Y gastric bypass instead of helping those with insufficient weight loss or weight regain. So that's stated here. Of course, there are several options. The results might be a little bit disappointing, so let the first blow be the decisive one. And I think I should keep it with that for now.
Okay, thank you very much. We have several questions. One of the questions is, why don't you use an adjustable band? Because then you can adapt the amount of restriction, and one of our auditors has better experience with adjustable bands.
Yes. So I think it's a very smart question. That's something we also tried. So actually, first what we did with converting a adjustable gastric band as a primary procedure, when converting it to a Roux-en-Y gastric bypass, we left the band in place. 2 points on that. So one, we hardly ever changed the volume of the band. There was almost no necessity to there. And even when we inflated it, patients did not find a lot of difference there. And the other thing is, compared with the non-adjustable band we are using now, we saw quite a number of complications because an adjustable band is it's just a bigger device. There's a tubing there which might lead to internal herniation. It's less easy to fix to the pouch, so you might have a little bit higher number of slippage and even erosions. So that was the way to go there. And on the other side, when using a minimizer ring or another ring, you can also adjust the size. And in the case Professor Geven just explained, we've done that. We've also done that in the so we changed the diameter of the band. But in our experience on the other side, when people get real dysphagia from the ring, the only real option is to take it out, actually.
Maybe I can add a little bit to that, if I may. Sure. In fact, the patients that we converted from an adjustable band to an adjustable banded bypass do quite well in terms of weight loss. And it's not that many times that we needed to change the volume, but it's the concept of having a banded bypass. And the real problem is that, as Dr. Koerma already mentioned, that in a number of these patients, we had problems with the tubing. That's something we solved by placing the tubing in the end, peritoneal. But the real issue is that, and that is surprising to find, that a number of these patients, we use the excluded stomach to fix the band in place. And we've had at least 3 or 4 erosions into the excluded stomach, often in patients that are even asymptomatic. But of course, is a reason to remove the band. So we really stopped doing that, although we did quite a large number. And when a patient has problems of whatever kind, even when it's not band related, we tend to take the band out and replace it by the minimizer. So we stopped doing that.
Okay, thank you very much. So we go to our last lecture. We still have some questions that we might take at the end. And Jan Willem, we have now a video session on band-related complication. And maybe to start with, one of the questions was the 1 to 3% of band erosion. Do they compare to the adjustable gastric band? So please, the stage is yours.
Thank you. Well, I don't have a case with the erosion in this series because they are all, most of them are managed endoscopically. The percentage is similar or even a bit higher. Oh, my watch is making fun out of me. So the percentage is probably about 1% of erosions of this small band. But the big difference, of course, is that the problem of an eroded ring is minor compared to an eroded adjustable gastric band with the tubing attached to it, with the large size And when you leave a eroded adjustable gastric band and you don't take it out quickly, you can even have that migrating into the small bowel, causing a lot of complications. So just to summarize, you have a number of potential band-related complications. As mentioned, the band erosion can be early, and probably that's a technical problem. You place the band too close to the gastric wall or even through the gastric wall. The late, well, that is what we see with any foreign body. Your body will try to get rid of it, so it can grow into the stomach. Band dislocation malposition is a potential complication. The band can be too tight, and it can be perfect for one patient and the same size will be too tight for another. So it's really patient related. And sometimes, and you saw it in our results, we have to remove the band because there's really an intolerance of the size of the band. But these patients would probably have done very well without a band as well. But it's a small percentage. And that, of course, can result in excessive weight loss and a lot of issues. And then a peculiar complication, herniation of pouch and or bowel through the band. Very quickly, this is one of our cases, very sufficient weight loss after a banded bypass, doing very well. Very nice % excess weight loss. She had some complications on the road that were not bypass related. She had a perforated diverticulitis. In the end, she ended up with a sigmoid resection, and then she developed weight regain and pain. Now, this is the barium swallow, and when you look closely, you see that here is the ring. I hope you can see my pointer. I can take the other one. And the ring is about here, but you also see that the excluded stomach is showing contrast. And that's, of course, a clear indication for a gastrogastric fistula. Several options here. You can place a stent, but that will not close the gastrogastric fistula. You can try to close it endoscopically, or you can do that surgically. And this is what we did, and I hope the video shows well on your screen. I reduced the size of it to make it look a bit more fluent. Some adhesions, usually they are very limited. I'll just move on a little bit. You have to remove all the adhesions. You also see that this patient had a hiatal hernia. Here is the band, and then we tried to find the location of the fistula. Maybe I passed that part already. That was just below the level of the minimizer ring. Now we are going to cut the jejunum and then just take the part with the fistula out. Here you see the band. So the band was not, in this case, the cause of the gastrogastric fistula. It was just on top of it. The fistula is right here. Here you see the opening of the fistula. Again, there is we opened it up to find it. Here's the fistula. But the band is on above that. There are no signs of erosion of the band, so that was just unfortunate, I think. And we solved it by cutting out the fistula, reducing the pouch. But in this time, we didn't leave a ring after the procedure was finished. And of course, we did repair of the hiatal hernia. So here you see how the pouch is reduced. And the hiatal hernia is closed with a new gastrojejunostomy. If there's any questions, please shout. But I just continue with another case. Again, banded bypass, really excellent weight loss again, with up to 40% total weight loss. But then she developed recurrent pain, body mass index of 26, and remission of her hypertension, and had symptoms of an internal hernia. She got surgery for that. It was found, the hernia was closed, but then a little bit later she developed severe dysphagia. and was losing more weight. And BMI of 26 is already okay, but going much lower is probably too much. And this is what we saw on the barium swallow. A large pouch here filled with marshmallow to test the outlet. The band is right there. You can see it. And what you see and we may appreciate is that the band actually is on the gastrojejunostomy. So it probably dislocated because as I mentioned, we place it about 2 centimeters above the gastrojejunostomy. And here is a very clear picture of a stenosis at the level of the band with a dilation of the pouch above that. And when you see this dilated pouch, you know that it will not function properly. And we went on to do revisional surgery. The patient had some more procedures. You can see she had a hernia for which a intraperitoneal mesh was placed. Again, you have to take down all the adhesions, find the band, clear the hiatus, and we quite often find a hiatal hernia there as well. It was on the barium swallow visible as well. Very important to completely release all the adhesions at the area of the hiatus and to get the adhesions between the pouch and the excluded stomach all taken out, because you need to resize the pouch after what you saw on the swallow. Now here you can see that this band can also be opened, put at the side to do a resizing of the pouch. It's a little trick. You have to place your clamps and then rotate carefully and slowly, and then it will open up. The pouch is, as you can see, very dilated, too big. So we take a bit out, as you can see right here. And then the band is replaced. It's a bit more complicated, and the company will probably tell you to buy a new band, but you can reuse it and replace it, close it again. You can see that we put a clamp on the notch to prevent that it goes too tight. That's also a little trick. And then, of course, the band is fixed again. Hiatal hernia is closed, but that is a standard type of procedure. And that's the end of this case with fixing the band to the gastric pouch. And again, it has 2 fixation points, one in the mesentery, and the other side is with the proline sutures on the rings of the minimizer band. And if you're still courageous enough to stay and keep watching, I have one last case. This patient was very happy after redo, gained a little bit of weight, and then was stable. And this is case number 3. She had a gastric bypass, and after, I forgot to put in the number, but after about 2 years, she developed dysphagia. And we, of course, did an evaluation of that. We did a barium swallow, we did an endoscopy. This is the barium swallow. And what you can see, and this is a picture that the people that have done adjustable bands in the past can really appreciate. The band is in a rotated position. It should be 45 degrees in this direction instead of in this direction. So here's clearly a herniation through the band, pushing the band down. And here you see the short video of a swallow. You see that it's a big pouch, looks like a big pouch with a very narrow outlet, and you can imagine that the patient had a lot of complaints from that. So here we did the endoscopy, and the endoscopy will be followed by the surgical procedure. The gastroenterologist could pass into the small bowel, as you can see here, but it was quite in a sharp angle, and he also suggested, is this not a herniation of the pouch and small bowel through the ring? And this is what you find on laparoscopy. The band is right there. You see that there is a bulging pouch, and in the end we knew that it was small bowel above the band. The sutures are still in place. That's important to realize, that it was not that the sutures were displaced, but the pouch and small bowel herniated alongside of the sutures. Now here, of course, again, it's important to completely release the band, and it's best done with diathermia, because when you use a harmonic, you certainly will damage the band. And diathermia is very good. You can just go on top of the silicone, nothing will happen. There was no need to open up the band here, but we were able to reduce the herniated pouch and small bowel through the ring. And then it's very important to take down all the adhesions, because there were a lot of adhesions of omentum and etc. to the small bowel and to the pouch, to be able to really correctly position it and then refixate the band in position. So here you see all these adhesions that were taken, but were moving upwards through the band. So take them away, take it out, make it look like the original situation again. And then, as you can see, that right here, and then the band is refixated. And here I did an additional suture, something that we used to do with the adjustable band, of course, making a gastrogastric suture over the band, hopefully to keep it better in place after this revision. This patient was in daycare surgery and could immediately eat normal again, that as he used to before the herniation. So to conclude, well, it's obvious when you put in a foreign body, complications can occur, but the duration rate is not 7%, as in one study was shown, but usually when it's about 1%, it's okay, easily to manage. When the patient has complaints, you have to exclude band problems, of course, but when you look at the overall picture, and the long-term effect on weight loss with a band really outweighs the potential complications. So I think that's everything I wanted to show to you all. Thank you.
Thank you very much, Jan-Willem. Fantastic talk, very interesting videos. We have several questions from our attendees. One of the questions is, do you close the band with the bougie in place or not?
No, we don't. We have a very standardized pouch, which is calibrated over a Sharia 40 tube. And then we do a very standardized size of the ring, which is 7 centimeters in the female patient, 7.5 in the male, as Dr. Boerma already mentioned. And we also use a 7.5 centimeter size in redo patients. Initially, we did 6.5 centimeters because that's what we did with our stylistic tubing. But when you looked at the inner diameter, the 6.5 diameter of the minimizer is less than that. So we went up to 7, and we have a very acceptable number of patients with dysphagia.
Great. Another question was, what is the size of your linear gastrojejunostomy?
We try
about
to
3 centimeters. But the size of the gastrojejunostomy is not really very important, because the size of your pouch is important, and that size is limited by the ring.
Okay.
But in fact, when you look at the videos of our operations after placing the ring, it's really loose. There is no tightening of the pouch. There's no restriction at that time.
It becomes restrictive with time.
Yes, when the pouch starts to expand, then it becomes restrictive.
Yeah.
And it also teaches, I think it also teaches patients to eat a little bit different, eat slower, chew better, and all these things. So which is also, I think, very pro of the band there.
Definitely.
Another question maybe to Dr. Burma was, one anastomosis gastric bypass. Should we ban this type of pouch?
Mm-hmm. Yeah, that's an interesting question, I think. We might. To turn it around, what we are doing nowadays, in this series I've just showed you, we made a pouch about 5 to 7 centimeters, and following up with the very impressive results of the one anastomosis gastric bypass, we are actually taking a longer pouch nowadays in our Roux-en-Y gastric bypass. We in our center have a bit doubts about the possible biliary reflux effects on the long term in one anastomosis. So we tend to go with the best of both worlds, a little bit longer pouch in your Roux-en-Y gastric bypass. So that's the way we try to go there.
So I want to challenge you with another question. A long and narrow pouch leads to a delayed emptying of the pouch. So this should be also part of the banded, or is part of the principle of the banded gastric bypass, number one. And number two, a long and narrow pouch is less prone to dilatation. So why do you think that a long and narrow pouch should be banded?
Well, that's a simple question. Even when you do a long and narrow sleeve, it will dilate. So it will be at a slower rate, but it will dilate. And,
yes,
and that is true for all types of pouches that you make.
This leads
smaller,
to
more vertical, the less tendency, but it will dilate.
Yes, this leads to another question. You showed in your video a de novo hiatal hernia. And this is the same is true for the sleeves. In the sleeves, we also see in our series with 10 years results, 40% de novo hiatal hernia. And my explanation for that is the sleeve is a high pressure system that leads in the long-term run to a weakening of the LES. And I believe with the banded Roux-en-Y gastric bypass, you have a similar system. And the question to you is now, do the patients experience, especially in the long-term follow-up, more reflux symptoms? And how often do you see this de novo hiatal hernia?
So I think the number of cases complaining about reflux is rather low. But sometimes we see another problem of the hiatal hernias, which is dysphagia, because if they get a hiatal hernia and the pouch herniates up a little bit and the ring gets stuck in the hiatus, then sometimes people get dysphagia. I'm not sure the number of hiatal hernias de novo we see in our series. I think we should look back at that. But I think also in revisional surgery, it's something we really should take better care of, looking at the hiatus, because if you leave a part of the stomach up in the mediastinum, that will definitely be the problem in your patient after the conversion. So we tend to free up both the crust and pull down the whole stomach and thoroughly sleeve that down to make a really small and narrow pouch, I think.
I'd like to add something to that, because yes, the sleeve is a high pressure system and it will affect your lower esophageal sphincter, but what we see are sliding hiatal hernia. So the whole complex of the stomach and the cardia is going up, or the pouch. And that is what you see quite often. And I personally think that part of that is due to the weight loss. You have a lot of fat around the stomach in the hiatus that disappears, making the opening larger. And that can cause a sliding hiatal hernia. The thing is, when you repair the hernia, the patients still have the same lower esophageal sphincter, but then they don't have the complaints anymore. So that's different from having a insufficient LES with reflux, whether it's with a bypass or whether it's sleeve. So they really develop sliding hernia.
Great. So I just want to mention that all the questions will be answered in a written form later on, because we will not be able to cover all the questions now during the webinar. But maybe one more very interesting one. Is a larger band better? Will it have less slippage, less migration, like an adjustable gastric band? Is one of the questions of our attendees.
Larger in width, you mean, or larger in size?
Not in width, but in size, in height of the band.
Yeah, I don't think that it will make a real big difference. And the risk, the larger the device, the higher the risk of erosion. That's, I think, what has been shown in the past doing non-adjustable bands on the stomach. That's where it started with bending. They did non-adjustable bands, but there were a lot of issues there. And these were usually wider bands. So I think the band should be small sized, because it is just there to prevent the pouch from expanding. When it does that, the patient will feel restriction and should start changing the eating behavior.
Another question is, what about wrapping the pouch with absorbable materials? Here it's mentioned vicryl mesh, but you could also think of an absorbable hernia mesh.
Well, I think that first of all, you need to preserve your vasculature.
Blood
so
supply.
you will have the limitation there at the lesser curve anyway. And an absorbable mesh, it will maybe cause some restriction in the short term, but it disappears and then you're back to zero. So that's not a good idea.
And that's also the data you showed on the pericardial patch. I think short term it works, but long term it does not work. And I think the band is there for the long term results, not as much for the short term results.
Yeah. Well, that's an interesting remark, by the way, because we also place the band for the long term results. But in fact, when you look at the weight loss in the first year, even in the first year, despite really being restrictive, we see more weight loss in our patients compared to the other Dutch obesity clinics. So there is some effect of that band from the start.
We have several questions concerning banded sleeve, but we will not answer these questions right now because that might be another webinar. So to wrap it up, you have shown very, for me at least, convincing that the long-term 5 years results of the banded gastric bypass are superior to the non-banded Roux-en-Y gastric bypass. You showed that the complication rate of the band is somewhere between 1–2% in that range, that most of the erosions, which might be one of the most feared complications, can be solved by endoscopy. Yes, so for me, this was really convincing to do it, as you mentioned, the first time right. I personally use the bands for weight regain. So a different approach, but we learn our entire life. So maybe I will start changing, at least thinking about it.
You changed your mind now?
At least I think about it.
Very good.
Yes, so I wrap it up. All questions, as I mentioned, will be answered in a written way. I thank our attendees for listening to our webinar. I thank Bariatric Solutions for the organization, and especially to our two speakers for sharing their huge experience with us. Stay safe, thank you for attending, and see you next time for a similar webinar by Bariatric Solutions. Bye-bye.
Bye.
Garrett, thank you very much for moderating.
Thank you.
And have a nice day.
You too.